Here, Jackie, just give me a thumbs up. Good, hearing me okay and seeing the slide deck okay. We're so delighted to join you. Thank you so much for taking your time after hours to learn a little bit about anti-obesity medications this evening. And we're going to have some more people joining us. I am in the first few minutes just going to introduce myself and note the other MCT2D participants who are on the call with me, and then we'll get started talking. I'm Lauren Oshman. I'm a family physician, and the other hats that I wear, I am a diplomat of the American Board of Obesity Medicine, and I am a motivational interviewing trainer, as well as a co-program director for MCT2D. You'll also see Jackie Rao on the call as a co-host, and you'll see Heidi Dietz, our pharmacist, with us, and they'll put in the chat if I missed anybody. As we go along, if you have questions or comments or concerns, please put them in the chat. I'm going to ask Heidi and Jackie to monitor that for me, and we'll go through this presentation. I have a couple of poll questions to make this more interactive, and so we'll get to those in a bit. Really the point of this presentation today is to talk to you about a topic that's very interrelated to type 2 diabetes care, and that's obesity. So what I hope to cover is just a little bit about the relationship between obesity and diabetes, to talk you through the FDA-approved classes of medications for obesity, and to talk through the recent changes in the Medicaid formulary for anti-obesity medication coverage, and explain to you the prior authorization criteria that is going to be required to get these for your patients. So I hope by the end of this hour, you can compare and contrast medications, appreciate those prior authorization criteria, and then we will use some cases to think about how you might be using them. The term diabesity has been around longer than I thought. It's been around since the 1970s, and it really talks about this intersection between people who have overweight or obesity and people who have diabetes or pre-diabetic conditions like metabolic syndrome or insulin resistance, with this idea that they not only share common risk factors, but they share pathophysiology and respond to similar treatments. The vast majority of our patients with diabetes, at least type 2 diabetes, have overweight or obesity. And a recent study broke down new cases of diabetes and suggested that 30 to 50% were solely due to obesity as a risk factor. So it makes this compelling case that we can recognize patients along the diabetes continuum, from high risk due to obesity to prediabetes and diabetes, and that treating the underlying chronic condition of obesity needs to be a core component of treating diabesity. So comparing this old paradigm with a new paradigm, we might treat diabetes first with diet, medications, and monitoring, and then tackle overweight and obesity. And a new paradigm that I hope you will feel more confident about by the end of the talk is to treat overweight and obesity first, and then monitor for complications such as dyslipidemia, hypertension, and impaired glucose tolerance. Thinking then about the FDA-approved anti-obesity medications, I'm not going to talk about all of these in this next hour. Orlistat, which is spelled wrong here, Xenical or Ally as brand name. This is a pancreatic lipase inhibitor, which essentially causes fatty bowel movements. I don't use it very much in practice, and so I'm not going to spend a lot of your time talking about it today. Above that, you're going to see two medications, liraglutide and semaglutide, and you're going to see their brand names. These are the GLP receptor agonists that you're all comfortable using for diabetes treatment, branded and at doses to treat obesity. Above that, you're going to see a medication, naltrexone and bupropion. This is a combination of an opioid receptor antagonist and a dopamine norepinephrine reuptake inhibitor. And then above that, phentermine and topiramate, which is a combination of the sympathomimetic phentermine plus an anticonvulsant topiramate. And at the top, phentermine, which is the oldest anti-obesity medication, which is just a sympathomimetic medication. Interestingly, these medications all work in the same way. They work to reduce appetite, to reduce food consumption, and in some ways to increase energy expenditure. There are, however, a host of other medications that we use to treat obesity. You'll see here in this FDA approved a slightly expanded list of several of the phentermine-like compounds: diethylpropion, phendimetrazine, and bensphetamine. Again, I don't use those as frequently in my clinical practice. And then you'll see medications for off-label use. Metformin, we all are familiar with. SGLT2s, we've talked in previous presentations about how they can be anti-obesogenic. They can help with weight loss. Topiramate and zonisamide, medications that can also have some actions to reduce weight. And then in the future pipeline, I'm not going to go over all of these medications today, but there's some very, very exciting work being done with medications that are improving the efficacy of anti-obesity treatment. So I told you how anti-obesity medications work. They reduce appetite, they reduce food consumption. It can go on levels of increasing complexity, talking about brain chemistry. I'm not going to go into detail into the hypothalamic pathways that these medications work on, but suffice it to say, most medications work at the same hypothalamic focus in the brain to reduce hunger, appetite, and food consumption. Bupropion, interestingly enough, works to stimulate these cells to reduce appetite, and then naltrexone blocks a feedback loop. It actually makes the bupropion more effective. Phentermine and topiramate also probably have mechanisms of action through a GABA pathway that increase energy expenditure and also induce satiety. And the GLPs, as we've talked about in prior presentation, have a profound effect on slowing gastric emptying, increasing that sense of satiety and fullness, and slowing down eating behaviors. So I'm going to start with our first case. This is LJ, and all of these patients are, people or combinations of people that I've seen in the last few weeks, and I was thinking about in sharing this presentation with you. So she's a 45-year-old female. She has type 2 diabetes, and her A1C is about 11. She has a history of heart disease. Her body mass index is 45, and she has asthma. As I said, her A1C is 11, her microalbumin test is negative, she has normal kidney function, and her weight gain, she says, is due to COVID-19. She was doing okay, but then had a pretty significant weight gain. She tells me in the past she has lost weight with Weight Watchers, but she just says, I feel hungry all the time. I feel like I have no control over my hunger. So I'm giving you her current height and her current weight, and then I want to give you her medication list. She is on metformin. She's on a sulfonylurea. She takes albuterol and aspirin, atorvastatin and fluticasone, lisinopril, and metoprolol. So I'm going to ask to have a poll brought up and see if we can do that for you. This is our technical challenge. And I'm going to ask you to pick which one of these medications do you think is contributing to obesity for her? Looking at the other medications on her list, there certainly might be others, but which one of these medications do you think is obesogenic to say is contributing or could be a risk factor for obesity? So I'm going to give you another 15 seconds. Then let's go ahead and end that poll and share the results. So most of you picked glipizide, and that's what I would have picked for this patient. So I'm going to move on to the next slide and we can stop sharing. Really the biggest issue for this patient is her use of sulfonylureas. And so what I would say in clinical practice is that every person is different, right? A medication for one person might interact with their chemistry and be more obesogenic than for someone else. But in clinical studies, the sulfonylureas do have about a 2 to 3 kilogram weight increase noted. Metoprolol is the other medication. And for your patients, they may need that medication. You may not want to stop it. But if it's just a medication for blood pressure control, hypertension, you may want to think about switching that to another medication, because metoprolol, again, beta blockers in some ways, reduced energy expenditure and some other mechanisms that can be obesogenic. So when I meet with patients, I typically look at their weight history. And so if they've been a patient with me for a long time, I can use our medical chart and look at that weight graph. But for this patient, I asked her to tell me, what happened in your life? What was going on that caused you to have weight gain? And we really identified her pregnancy as the first piece of what changed her weight. She then started working a night shift job as a nurse, and so she was quite sedentary during the daytime. She was eating more processed food, and she had that circadian rhythm disruption. She was then diagnosed with hypertension and, unfortunately, this very early onset heart disease for her, and placed on 2 medications that are probably having something to do with her weight staying where it is. And then you can see, again, she used Weight Watchers, but it was only helpful until she says, I stopped it. I couldn't stick with it. I just felt too hungry. She was unable to continue that low-calorie diet plan. So my next question for you, I know we haven't gotten in the details, but I'm just curious to see what you'd pick. I'm going to start the next poll number 2, and ask you, which medication would you choose for this patient? As you see here, I'm using a graphic that was taken from a recent study by a doctor named Acosta, really talking a little bit about not only do these medications work to reduce appetite, but maybe they have other things that would make them more effective for certain patients. So phentermine topiramate might work for someone who isn't satiated. They don't feel full at the end of their meals. Bupropion and naltrexone for someone who has addiction issues, food addiction or emotional eating. Hungry gut, someone who feels hungry all the time. They eat and then a few hours later they're hungry again. Thinking about that slowing gastric emptying. And then phentermine, really thinking about their metabolism. So for some patients, we find that their metabolism is significantly slowed. So I'm going to go ahead and end that poll and show you your results. Many of you picked liraglutide. And as we're talking about obesity treatment in the context of diabetes care, I think, clearly we're going to be selecting for many patients an anti-diabetes medication if they're not already on it. For this particular patient, we're also seeing her typology, this idea of being hungry all the time. As we shared with you in a prior presentation, patients who are taking GLP will often tell me, I don't feel hungry anymore. I can't eat anymore. My stomach just feels full with a smaller amount of food. So I'm to go a little bit for each of our medications into a mechanism of action. Just as a reminder, semaglutide and liraglutide are the 2 FDA-approved medications, just giving you semaglutide as an example here. It increases satiety and decreases gastric emptying. Satiety is the official term for staying full between meals. For dosing of this medication, like many of our other GLPs, you're starting at a low dose weekly because of that early nausea and sometimes constipation patients will experience, and then titrating it monthly up to a maximum dose, if you wish, of 2.4 milligrams. There are very few contraindications. So for patients with heart disease or other disorders where they're on a long list of other medications, this is also very helpful. So that contraindication is really only medullary thyroid cancer, MEN2 syndrome, pregnancy or lactation. And, as I'm sure you know, nausea is really the most common side effect. Headache, acid reflux, constipation. Pancreatitis probably isn't a side effect of the GLPs, but someone who has chronic pancreatitis, I wouldn't use it for them. Gallstones, especially with rapid weight loss, can be another side effect of these medications, as well as concern for watching for renal impairment. Most of that is due to the nausea and dehydration that you might experience, then worsening it. And if they're on other medications that can cause hypoglycemia, watching that. So we tell patients, eat slow and smaller portions, and for many people, it goes away with time. I'm just going to show you one kind of study slide for each of these medication classes. And so this study in 2021, the STEP 2 trial, was looking at semaglutide 2.4 in people with overweight and obesity and type 2 diabetes. And what you can appreciate is, compared to the placebo, where patients lost about 2% of their body weight, lower dose semaglutide, which is currently approved under brand name Ozempic for diabetes, and higher dose semaglutide, that the higher dose semaglutide gets you to the higher body weight percent change. You will also see that people with type 2 diabetes had a less robust response and less robust weight gain than people with just obesity. So we keep that in mind. But we also know that a 5 to 15% weight loss can improve type 2 diabetes control. So we can see on the right, the pink, the semaglutide 2.4, a larger proportion of patients lost that higher percent of weight that I would hypothesize is going to help with their diabetes. Just for your reference later on, I'm giving you this slide deck, giving you the information about titration of the medications. Liraglutide, or brand name Saxenda, is titrated daily and the dose is titrated, is given daily and titrated weekly. Semaglutide is given weekly and titrated monthly. You can always go slower if the patient is having adverse effects. If someone's experiencing very good weight loss, I won't always go up to the top dose. I think it's patient dependent. So here are your considerations. If you've got a patient who's on a type 2 diabetes medication, particularly with Medicaid, they are having insufficient weight loss with the top dose of liraglutide or semaglutide, or they need more A1C lowering efficacy, you could consider moving them to the obesity treatment dose, which would be 3.0 milligrams for liraglutide or 2.4 milligrams for semaglutide. However, I think as of last week, semaglutide 2.0 was approved for the FDA. Our pharmacist, Heidi, if I forgot to email her this morning, I meant to ask, can we get that in a pharmacy anywhere yet? So I'll ask her to type into the chat if she knows. And then the sad news is that semaglutide has had supply chain issues. So just in the last few weeks, I have stopped initiating that for patients. I am starting them on liraglutide now because semaglutide typically has not been available in the pharmacy. So what do? Supply chain issues. You need to switch medications for a patient. This is from a 2020 article. I think it's just helpful, even though this is very intuitive, to think about for a daily medication, switching to the weekly, for a weekly medication, waiting a week and switching to the daily until it's out of your system. And then looking at some of those dose equivalents if you need help switching. Sometimes I'll go down a dose if I think the patient might be sensitive to it. So I'm going to give you, go ahead.
There's a quick question in the chat. Are higher doses associated with worse side effects and risks?
I would say in my clinical experience, it's starting the medication that is associated with the side effects and risks. And so I haven't noticed a huge difference. I've had very few patients who've had a recurrence or worsening side effects on the 2.4 of semaglutide, for example, than 1.0. But I have had some patients who kind of are limited at that lower dose. So moving on, thank you. Yes, it's available. So that was your other, very topical point, at least now as we're recording this, that if you've got patients who are having type 2 diabetes and obesity, you're also welcome to use that 2.0 milligram dose. I don't know if we have data comparatively saying which was better, but they're pretty similar in terms of doses. So I'm just giving you a case formulation about how we think of this comprehensive treatment for obesity for each patient, even though we're focused on medications here. And, really when I do nutrition teaching with patients, it may be a long time before they can get in to see my nutritionist. So I talk about plate planning. They can have similar medications as they would, but they're going to have a larger portion of protein and vegetables and a smaller portion of carbohydrate. For activity, I have patients set an activity goal. So we know for weight maintenance, 150 to 300 minutes of activity a week are necessary or associated with continuing to keep weight off. But for this patient, she said, you know what, I can commit to doing some short walks twice a day, and that's wonderful. We also talk about resistance training because we know when we lose weight, we lose some muscle mass. So we set a SMART goal. We stopped her glipizide and were able to titrate her off metoprolol, working with her cardiologist, and we started semaglutide. And she said, I feel great. I don't feel hungry anymore. That feeling of hungry all the time is gone. And she was more able to stick with her plan. And so she experienced improvement in her diabetes care, her hypertension, and her asthma is under better control. I'm going to switch over to another case and tell you about patient MD. He's a 67-year-old male. He has type 2 diabetes. A1C is pretty well controlled at 6.8. BMI is 45. He has some complications of retinopathy, neuropathy, and CKD3. He has past medical history as listed here with some chronic low back pain and depression. I didn't change this, so we'll change this for our follow-up, but pretend his A1C is 6.8 and not 10. His creatinine is 1.7 and GFR is 47. And he was sent back to me by his orthopedic surgeon. He said, I need to lose some weight. My surgeon said I needed to lose weight. So he recently made some pretty impressive lifestyle changes. He quit alcohol, working really hard on quitting smoking. He's down to just a few cigarettes a day, and he's just having a terrible trouble with sweets and reporting he's having a lot of emotional eating. He said, you know what they say about cookies, when you open a sleeve, it's an empty sleeve. So I'm going to show you his medications and then bring up that same poll and ask you which one of the following medications do you think is potentially obesogenic for him? Is it empagliflozin, metformin, valsartan hydrochlorothiazide, rosuvastatin, paroxetine? Sorry, I didn't put paroxetine on this one, or gabapentin. Which one do you think? I was trying to give you poll questions that were not multiple choice. All right, so let's close down that poll and show you the answers. So most of you selected gabapentin, and for this particular patient, there are two medications that are potentially obesogenic for him. Paroxetine of the SSRIs is the most likely to cause weight gain. So one intervention I do with many patients I'm working with are seeing about changing their SSRI to a different medication. And then gabapentin, again, in average clinical studies, 2.2 kilograms of weight gain. I have some patients, it seems to do nothing. I've had other patients who quite literally have a 10 or 20 pound weight gain with gabapentin. They're miserable because of their pain, but the medication can also have side effects. So just again, something to think about with pain medications and depression medications as you're treating your patients. So let's move on to that next poll question. And for this patient, which one do you think you might choose? He's already on SGLT2 inhibitor. He's not on a GLP. His diabetes is pretty well controlled. Which one do you think might be a good choice for him? And there's really no right answer here. And as we'll get to later on in the presentation, so much of it has to do with insurance coverage. Alrighty, I'm going to shut down the poll and show you your answers. A little bit more split here. So phentermine topiramate, we'll talk about contraindications versus precautions for this patient. Bupropion naltrexone, thinking about that emotional brain and emotional eating would be a very reasonable choice. No contraindications to liraglutide might be an absolutely acceptable choice for this patient. And phentermine, again, we'll talk about kind of the short-term coverage and rules around phentermine use. So we'll stop sharing and then move on and tell you a little bit about what I chose for this patient, which was bupropion naltrexone. Lost track of my clicker here. So bupropion naltrexone combination of bupropion, dopamine, norepinephrine reuptake inhibitor, and an opioid antagonist. Titration I'll show you in a little bit more detail on the next slide. Only precaution is CYP-T2B6 inhibitors. Contraindications to be aware of would just be uncontrolled hypertension. It's going to be the naltrexone and the bupropion component that has a seizure precaution and some eating disorder precautions on it, or someone who's just abruptly recently stopped alcohol, a benzo, barbiturates, or anti-epileptic medications. Chronic opioid use, not great with naltrexone, and then MAOI use is on that label. In terms of adverse events or reactions, there's a black box warning on every SSRI, SNRI, and bupropion about suicidal thoughts. If you ask psychiatrists, it happens. It's something I talk to patients about. It's exceedingly rare. And then any of you who've used naltrexone for alcohol use disorder, nausea is significant. And for people who aren't using alcohol, probably more significant than for my patients who are using it for that. Headaches, insomnia, dizziness. Those are the side effects I talk to patients about. And so we counsel them about avoiding opioid use and a little bit about that blood pressure and pulse monitoring. So titration for this medication, it's just a single dose pill. So starting with the first week, just one pill, one twice a day, 2 in the morning, 1 in the afternoon. And then after that, week 4 subsequently, 2 tablets twice a day. Interestingly enough, high-fat meals increase the systemic absorption of those medications. There is liver metabolism, so I don't give it to people with acute hepatitis or liver failure, and just remembering that dose reduction just for that one issue. So I'm going to move on and talk to you in a little bit more detail because I think we don't always think about these potential risks or side effects. We talked about the black box warning, just monitoring symptoms. I've had patients with bupropion have their anxiety worsen and some where it's fine. Blood pressure and pulse, I think interestingly enough, bupropion may elevate blood pressure and heart rate even more often than phentermine. Studies on this drug didn't include anybody who had a heart attack or stroke in the prior 6 months, arrhythmias, congestive heart failure. So I would just exercise caution in those groups of patients with this medication because we don't really know. The diabetes medications all have cardiovascular outcomes trials. We're all looking at those outcomes, not so with bupropion and naltrexone. We don't really know. So the label is going to recommend monitoring blood pressure and pulse before and during treatment, particularly if that patient has had controlled hypertension and you're starting this medication. So just something to think about for monitoring. And just again, one slide to show you a little bit from the naltrexone bupropion clinical study. And these clinical studies were certainly all pharmaceutical company funded. These were the studies that got these medications approved. And so looking at body weight reduction, placebo versus the bupropion naltrexone at about 5%, as well as A1C reduction. So I think this is interesting just to know that when we treat obesity, we treat diabetes as well. So seeing some improvement in A1C, even though this medication doesn't have any hypoglycemic action. So looking at different clinical studies, especially in patients without diabetes, you'll see more robust weight loss. What I tell patients is that the medicines are individualized. I'm going to start it for you, see what you're experiencing with weight loss, and if it's not working for you, I'll switch to something else. So just giving you that case formulation for this patient, he was interested in having some lower carbohydrate snacks and more protein, kind of getting at that emotional eating and meal planning. So a lot of the behavior work with him, we did some worksheets and some cognitive planning for what he was going to do when he had those emotional feelings instead of eating those high sugar, carbohydrate, high snacks. At our local fitness center, we have a program called MyFitRx. And so for his exercise regimen, he opted to go into a jumpstart program for exercise. And then I worked with him to taper off his paroxetine just to see how he would do with bupropion for mood. And it actually works quite well for him. We were able to taper off his gabapentin as he started to lose weight, and he achieved 10% body weight and really felt just, again, better in control of his emotional eating. He was able to stop smoking. That's the other clue in this case. Someone who's smoking, bupropion might be a good choice. And then it's just been really wonderful seeing patients with back pain experience some weight loss and cancel their steroid injection or feel like they didn't need interventions. And that happened for this patient. So here's our last case, CM. She's 52. She has prediabetes. Her A1C is 6.1. Her BMI is 42. Past medical history, anxiety, depression, insomnia, chronic acid reflux, really, severely affecting her IBS, non-alcoholic fatty liver disease, and nephrolithiasis. And she just came in feeling like she couldn't possibly try any changes with her diet. She felt bloated all the time, so she was just on a very carbohydrate-heavy diet, and she was very sedentary. She felt uncomfortable, bloated, and she just wasn't active. And so some of that kind of low energy, low activation that she was experiencing. So her medications are escitalopram, omeprazole, and hydroxyzine that she takes at night for sleep. And she is allergic to metformin. I guess it's not an allergy. Patients tell you they're allergic to metformin. What they really mean is they just have really severe diarrhea and you better not try it again. And I tried her on semaglutide and she had severe abdominal pain. She just couldn't tolerate it. So we know that's not in the cards for her. So this is actually a screenshot from our medical record for test patient. And so if you can imagine, patient diagnosed with depression and irritable bowel syndrome, kind of stops moving as much, changes her diet, not as active, sees some weight gain from her baseline of 165. And then over the COVID-19 pandemic, the majority of people who are seeing me just have had worsening weight gain and worsening anxiety. Some of it is because of stress. Some of it is because of illness. Some of it is because moving to work at home, I just find people are very, very sedentary and then going to the kitchen and eating more. So her anxiety got worse. That's where she started hydroxyzine, and you can see some of that effect with her weight gain going up. So I'm going to ask you a final poll question. Which anti-obesity medication would you choose for this patient? Would you choose phentermine topiramate, bupropion, naltrexone, liraglutide, or plain phentermine? And then we'll go over our last couple of medications in detail and leave some time for wrap-up questions and talking about the Medicaid prior authorization criteria. All right, so let's close down that poll. And again, I think there really is no right answer here. I'll tell you why I chose what I chose. I think for this particular patient with the liraglutide, she's had such severe abdominal pain that I might try it in the future for her if her IBS was better controlled. But I think from a trust perspective, we weren't going there. So I'm going to stop sharing those poll answers and then talk to you about what I wanted to choose for her, which was phentermine topiramate. And again, that activation, the patient who's sitting around all the time, very sedentary and depressed and not moving, one might hypothesize or think that phentermine would be helpful in that situation, as well as topiramate, which acts as an anticonvulsant. And interestingly enough, I read that the carbonic anhydrase inhibition might have some effect on taste. So again, thinking about all of those mechanisms that might change food and eating behaviors. Phentermine topiramate starts at a very low dose. Again, it's a combination medication, long acting, and then can be titrated up to a maximum dose of 15 milligrams of phentermine and 92 milligrams of topiramate, which, as we'll see, is much lower than what we might be prescribing for someone for headache prevention. There are some limitations with kidney impairment, so that would be a lower max dose for both kidney and liver impairment. Pregnancy and lactation, and we're going to get into more details. This is really the medication that you have to be super cautious with people who could become pregnant. Glaucoma, uncontrolled hyperthyroidism, and recent MAOI use. Really the relative contraindications are things to think about: tachycardia, someone who's already having depressed or suicidal thoughts, that warning is on topiramate as well. Sleep disturbance with the phentermine, topiramate, attention and memory disturbance, and then metabolic acidosis with that carbonic anhydrase inhibition. And then the side effects to counsel about really are more related to topiramate, and you're used to using this for other reasons: paresthesias, dizziness, that strange taste in the mouth, and then for phentermine, insomnia, constipation, and dry mouth. So for your reference later on, I just kind of am giving you the dosing. For most patients for phentermine topiramate, you would maintain them on 7.546 milligrams. But if after 3 months they're not having sufficient weight loss, you could try a higher dose if tolerated. And we'll get in more detail about all of these medications. What do you do if you're not seeing weight loss? You'll see on this one that it talks about tapering. That's actually from the headache prophylaxis guidelines for topiramate. So you're supposed to taper it down slowly. Probably not as important for weight loss in patients who don't have that co-occurring condition, but that's what is on the package label. So thinking about how to use this medications with people who are of childbearing potential, the manufacturer is going to recommend pregnancy testing prior to use and monthly, and is going to strongly recommend a highly effective contraceptive option because of the risk of oral cleft defects that is higher than a baseline risk. So patients may be recommended to use either a copper or levonorgestrel IUD or an implant or sterilization. Or picking methods to use together might be a estrogen progestin contraception, or a progestin only method plus a barrier method, or 2 barrier methods. So conversation I have with every patient, and again, that might be a reason that you would choose one medication versus another. So these slides are from what's called the CDC medical eligibility criteria, and these are contraception criteria for use. And what you're going to see is that not only does topiramate cause a risk of birth defects, cleft defects, but it also is a CYP3A4 inducer and may reduce effectiveness of combined estrogen, progesterone, and progesterone-only pills. Now, the studies done on obesity, what we think is this is probably more related to the higher doses of medication that we use for headache prevention. Studies were not done on that 90 milligram dose for obesity, and that's likely not quite as risky for combined hormonal contraception, but there's just really not a lot of data there. So I would consider, if you're prescribing birth control, just to consider whether there's an alternative that a patient might want to use that's a copper hormonal IUD or implant, and if not, think about using that second method alongside their combined hormonal contraceptive and progesterone only pill. The other thing I wanted to talk about with phentermine topiramate is that it does increase your heart rate. So the study that is in their prescribing information, this is just screenshotted straight out of the prescribing information, shows this one point in time, which really would suggest to you that even the placebo-controlled patients had a pretty notable heart rate increase. And so in the prescribing information, it says monitor the heart rate, don't use if any recent MI, stroke, arrhythmia, congestive heart failure, caution with controlled hypertension, but it's not contraindicated. It's something you can use. I would just monitor it. Now, other studies looking at patients over time would suggest that both blood pressure goes down and heart rate is neutral. Because again, over time, people are having weight loss and that stabilizes it. This isn't something I worry too much about. I think, again, what's listed in their package labeling isn't what I've experienced in clinical practice. I do tell patients to monitor, and I monitor them closely. So just going through those relative contraindications again, metabolic acidosis having to do with the topiramate. So you're going to want to have caution, especially for people perhaps with renal disease. And then think about that keto diet, right? Maybe a slightly increased risk for metabolic acidosis. You would use caution if you're co-using it with other carbonic anhydrase inhibitors. I tell patients to drink a lot of water. I do check electrolytes after starting, and then I monitor for symptoms. Glaucoma, again, just something that's in the general warnings for topiramate. Relative contraindication, there is a small decrease in creatinine. So when I'm monitoring for bicarbonate levels, I will look at their GFR at about 4 weeks. Same as any other medication, if you're losing weight, you might develop hypoglycemia. You may need to adjust other medications. Low blood pressure might be an issue as well. And then we try to avoid with alcohol use. So poor CM, she comes back, she's, poor thing, got all of these problems in her IBS, and then I felt like, oh, I gave her a kidney stone. So you will have patients who are using topiramate who developed kidney stones, and we had to stop that medication for her. So for her, I elected just to use phentermine. Phentermine increases norepinephrine, probably has some other mechanisms of action. There are several different generic and brand name formulations. The dose can go from 15 to 37.5 milligrams, or there's a low dose phentermine that's 8 milligrams that could be given typically before breakfast and before lunch. Typically use the smallest dose, see how patients do, and then only adjust if needed. Contraindications are active heart disease, uncontrolled hypertension, hyperthyroidism, glaucoma, many of the same things we saw in phentermine topiramate. It's a Schedule IV controlled substance, so the more I prescribe it, the more I spend time doing controlled substance prescribing, but it can be a really useful medication for patients. Monitoring blood pressure, avoiding alcohol, and there is a warning on it about operating heavy machinery.
Dr. Oshman, there was a question in the chat. Do you worry about worsening her anxiety using phentermine?
Yeah, so there is some data that phentermine, while it's a sympathomimetic, does not have the same negative side effects as a ADHD medication, a stimulant might have. For my patients in general, I would say grab bag. Some people really feel like phentermine does worsen their anxiety. I've had patients have to stop it. And for other patients, they do fine. It's definitely something to tell patients about and have them monitor. And again, I feel like someone at a conference I was at last weekend was saying obesity treatment is where hypertension treatment was 20 years ago. We've got 4 medications. That's it. And phentermine is the only one who's generic. So I'll talk to you a little bit at the end about pipeline medications if you're interested. But I think really what we're getting at with this talk is individualizing treatment and finding the best match for that patient. So it's an excellent question. So getting to that same point, there really is no evidence of addiction or withdrawal. This medication does not work in the same way that stimulants work. There is no established relationship to cardiac valve disease or pulmonary hypertension. If you're old enough, you'll remember the medication fen-phen. It was the fenfluramine in that combination that had those risks. There were no particular studies on patients with cardiovascular disease. Again, blood pressure seems to be stable, and heart rate, it looks like increased by 1.8 millimeter of mercury by the end of a 6 and 12 month study. So it's something that I watch, but it's something that I typically feel comfortable as long as someone's blood pressure and heart rate are controlled. We're talking in Michigan where there's no limitations in prescribing phentermine long-term. In other states, you may find, particularly in Ohio, there's a limit of 3 months prescribing. The medication then needs to be discontinued. So some people will try it for 3 months, stop it for a month. If the patient's weight regains, start it again. If you're moving or working in other states, you really need to know what the state requires. In Michigan, we're able to prescribe this longer term. So people always ask me if there's only short-term approval by the FDA and you're using this kind of off-label long-term, how do you know if it works? So there are studies looking at change in weight over baseline. Short-term referent means they just got the medication every day. Short-term intermediate means they started and stopped it. Medium-term continuous and medium-term intermittent, the same thing, and then long-term. And what we find is that obesity is a chronic disease. It is a disease that is a metabolic and hormonal derangement. I wouldn't stop your blood pressure or your diabetes medication if it got better. And we find the same thing in obesity, that very, very few patients, I think, are benefited by short-term use of a medication. And so for our patient CM, we took some time breaking down her meals. And I think a little bit of this was cognitive as well, her fear about having worsening bloating, but she found that there were several proteins that she could tolerate. So we talked about protein. We introduced the idea of an anti-inflammatory diet. She really loved that. So we picked vegetables that were on a FODMAP friendly diet plan. And then I referred her kind of to a specific IBS focused nutritionist. She did not take up my recommendation to weight lift, but she said, I love Pilates. I'd like to start doing that, and agreed to do a brisk walk. So we set a SMART goal for activity. The insomnia and the hydroxyzine, just to go back to obesogenic medicines, especially at high doses and especially used every day, that can really have a large weight gain potential for some patients. We were able to continue phentermine. And so in her case, bloating has greatly improved. At this point, she's at 7% body weight, but she's moving more and she's doing more and feeling better. So I told you we would talk a little bit about what if the medication doesn't work. Typically, I'll start at the very lowest dose and do a 2-week med check to see if patients are having intolerable side effects. If they're doing well, I'll titrate into the effective dose range. If they're having adverse effects, we can go down to a lower dose or discontinue. At 3 months follow-up, I'm looking for better than placebo. And in most of these studies, placebo weight loss groups were about 3 to 5%. So if someone is not having 5% weight loss, I'll say, this isn't working for you. We can switch to something else. And then I will keep following up with them on a consistent basis. You know, if you imagine obesity, just like diabetes and hypertension, is one of those chronic diseases, I might see them at those 3 to 6 month intervals. Going back for the end of our talk to talk about Medicaid prior authorization criteria and what we're really looking to accomplish with weight loss. I like this chart because it just really helps you encapsulate what am I trying to accomplish and where do medications fit in. We know with intensive lifestyle change, most people lose about 5% of their body weight, and that's simply not sufficient for many people to achieve improvement in their comorbidities, ABCDs, or adiposity-based chronic diseases. And for diabetes, for many patients, they're going to need the assistance of medication to improve. Steatohepatitis is the area where 10% and possibly more is going to be needed to reverse that steatosis. So what are the barriers that we all experience? Our lack of training. I hope that you feel like you've gotten something out of this talk that's going to help you feel more confident. Lack of knowledge. So there are obesity guidelines from endocrinology groups and the Obesity Medicine Association. Truly lack of time. I'm spending 40 minutes in consultation with these patients. And so figuring out how you're going to do this is really important. but potentially giving people the wrong advice, telling people just eat less and exercise more when we find that that does not overcome the metabolic derangements, the sick fat disease that's causing them to have obesity, and obesity bias, right? Somehow not seeing obesity as the chronic disease that other chronic diseases are. Lack of insurance coverage and high copayments are absolutely a problem here. And what I find is that we don't get good at things that we can't prescribe. So when they're not covered, we as primary care physicians predominantly find that we're not developing strong experience with them. And then, you know, you may have an endocrinologist who has a particular expertise here, but who's the obesity specialist? Other than a bariatric surgeon, who do you send patients to for this type of consultation when you need more help? So I'm going to segue to Medicaid because this is important for us to appreciate. And this is really just a screenshot of the Medicaid formulary. As we talked about at the very beginning, there are several different formulations of the anorexiants or phentermine that are all listed here, as well as Qsymia, which is that combination. And then the fat absorption decreasing agent Zenical that I told you I don't use. The GLP agents, both Saxenda and Wegovy under their brand names, and Contrave, which is that combination of bupropion and naltrexone. All of these are covered on the formulary. And you'll see with each of them, PDLP, age, PA, just means they're on the PDL, the preferred drug list, and they have a prior authorization criteria.
Dr. Oshman, can I ask you a question before you move on? Well, the question in the chat was, if there isn't something you're able to switch a patient to due to comorbidities, side effects, insurance, would you plan to continue the original agent if there's above a 3% weight loss?
Yeah, absolutely. And, you know, thinking about none of this works without changes in lifestyle. None of this works without foundational changes in nutrition and some increase in activity. Hopefully to that goal, the medication is there to help. And so someone who's at like 6% weight loss and they're still not achieving more, but they're doing okay, I consider it part of their maintenance package. Someone might have an A1C of 12. I give them metformin, it's 10. I'm not going to take the metformin away. So, you know, in specialty practice, we will layer medications. We'll take away, we'll add lifestyle change. We might take away that hydroxyzine or metoprolol, switch them out for other medications, and we may layer anti-obesity medications. That's a little bit out of the scope of this talk, but certainly something that we do in practice. So I've given you this slide really only because it's the hyperlink to this PDF that has all of the prior authorization criteria. You'll scroll down to anti-obesity agents and it's going to give you the PDL preferred list. And then on the right, it's going to give you all of the checklists that you must achieve in order to get Medicaid to cover the medication. So it would be a patient who has obesity, BMI over 30, or a patient with a BMI over 27 with a comorbidity. The ones they have listed are hypertension, coronary artery disease, diabetes, dyslipidemia, or sleep apnea. There are others, but they are not in the reasons that we can use these medicines for Medicaid. There is probably a little bit of racial bias here, right? So for someone of Southeast Asian descent, abdominal obesity might be a significant problem with them, and that their BMI might be a little bit lower than this. So things we'll talk to Medicaid about in the future. They can't have any contraindications. They must not be pregnant or lactating. And you have to document that they've tried to lose weight in the last year, as well as notating that this is part of a comprehensive plan with a calorie and fat restricted diet and exercise regimen. So there's a standard form, and this is where your staff is going to get the information. But typically what I've been doing is just putting all of this in my progress note. So I started doing this, found that my first several were declined. And what I found is that I wasn't reading the criteria carefully enough. That BMI between 27 and 30, really just these comorbidities. I hadn't written an attestation that the patient had a prior weight loss attempt, and I didn't provide documentation of that specific diet and exercise plan. This is my dot phrase that I put into my progress notes now. This will be in your slide deck to use or amend as you like. I put in their starting weight and BMI. I categorize them obesity or overweight and provide their comorbidity. I have an attestation phrase, and then I just give details. What did they try to lose weight? What kind of specific calorie restricted diet and exercise regimen am I listing? And then Medicaid just wants you to make good use of the diabetes prevention program. And so patients with obesity are at high risk for diabetes. That is available to them if they don't have type 2 diabetes, something that you can use for peer support. Repeat prior authorizations, people need to have had at least 5% weight loss to continue the medication. And so after 6 months, you'll have to do a repeat authorization. So, really the only thing for me to think about is it's going to be a while for a patient to see a nutritionist and, they haven't really started a weight loss plan yet. I do talk to them about this. You got 6 months and then we may not get this medication reapproved. And so I really want to make sure I'm setting them up for success. So if it's going to take them a while to embark on their plan, even though our guidelines and pathophysiology would suggest the medication is necessary, I might delay start just for consideration of getting it covered. So the last thing I want to mention is Governor Whitmer authorizing April 7th, Senate Bill 247, the Prior Authorization Act. Doesn't affect us now. It's going to take about a year for this to go into effect, but it's going to require a standard electronic PA request process. And the PA requirements are based on peer-reviewed clinical review criteria. So they should be using these same guidelines that we're using to make sure medications are available to everyone. And if someone is going to deny medication, it's got to be a licensed physician reviewing that appeal. The part I'm more excited about is the timing. So an urgent PA has to be acted on within 72 hours and a standard within a week. And this performance-based PA program that's based on this gold card program from Blue Cross Blue Shield, at least that program says that, physicians who've had a 90% approval rate for PAs don't have to do prior auths. You're gold carded. So I will be thrilled when that goes into effect and hopefully will be part of that gold card population. So here's your to-do list. My aim for you is to try to start using anti-obesity medications for people with obesity on Medicaid who can benefit from them. So start thinking about who in your staff is going to help you with prior authorization. Just try it. Try for one patient that you feel confident about. See where any of those barriers are and make sure that you've addressed how your note is and those sorts of things so that you can get them covered. The last couple of things are just to say, man, there's a lot of things we can do to help type 2 diabetes and even think about remission. And so I wanted to leave you with maybe another webinar. We're going to talk about dietary approaches to diabetes remission. We talked about medication a lot today. This study is the DIRECT study, and it's looking at a calorie restricted diet for improving A1C. And what you're going to see, the orange and red are year 1 and 2. And the percent of people achieving remission of their type 2 diabetes, 86% at year 1, continuing to 70% at year 2 for people who went through this program. So there's going to be some exciting things for us in the future other than just treating diabetes as a chronic disease and seeing it get worse. The ADA, just to bring it back around to what did they say we should be doing? They do say that you can use a short-term, very low calorie diet with medical supervision. They absolutely want you to know that you can use anti-obesity medications as an adjunct to lifestyle change, and that reducing overall carbohydrates is probably good for glycemia, emphasizing that healthy diet. And, what I want to leave you with is that probably we should act sooner. Probably that time when you get diagnosed with diabetes, that first month or year, is the time before some of those metabolic processes become more difficult to treat. So start thinking about treating obesity first, diabetes prevention and remission. You're going to find these resources on our website. So if you go to MCT2D.org, the top bar says point of care tools. I am not going to make this sound better than it is. Coverage of these medications is really difficult. And this is another advocacy process that we're undertaking as a collaborative. I hate to show you the bad bingo card here, but Medicare doesn't cover anti-obesity medicines. And there is a national movement to pass the Treat and Reduce Obesity Act to get this changed. But it can be so frustrating treating these patients, but we'll continue to work on it. So that's all I have. I'm leaving just a couple of minutes for questions, but I'm very happy to stay on. You're welcome to enjoy the rest of your evening if you have no questions. And I really do hope that you found something useful out of this hour. So if anyone has questions, put them in the chat. Unmute yourself. Heidi, I'll ask you to unmute. It sounds like some people do have semaglutide 2 milligrams.
Yeah, and my colleague Jessica wrote in too. So I've called around mail order that we use for a lot of our U of M employees. They stock it, and they have it, most importantly.
Yeah, and I think depending on where you are in the state and your primary insurer, we've talked about carve-outs for other medications. Either we can get information from the insurance company and the pharmacy benefit manager, or their employer might have decided something else. So if you've got an employer that you can convince to cover anti-obesity medicines, please help us do that work.
Question in the chat: what's the best way to treat nausea associated with the GLP-1 agonists?
Great question. Eat slower, less food. Don't fill up your stomach. I think, Heidi and I, we've talked about this before, that patients eat like they've always eaten, even though their stomach is a different stomach. So I typically just go through in detail that idea of slowing down. You can prescribe anti-nausea medications short-term. If people are having really bad acid reflux, you could prescribe a PPI or H2 blocker short-term. Heidi, anything else to add that we talked about in those prior talks?
No, I think the big thing is assessing the nausea. I often ask my patient, is it all day long or is it episodic around the meal? Because if it tends to be episodic around the meal, then I focus on those things that you just mentioned. Less food and slow down, and then I don't have to go to the other options. But
yeah, and I don't know, I would say 9 out of 10, I would say the vast majority of patients end up doing okay on these medications. And I'll even show them some of the slides from the clinical studies showing that by 14 days, the nausea is improving, letting them know. I think many people just associate it with understanding that their food consumption is going down. I have had patients that don't tolerate it.
And I think too, you mentioned this earlier, is making that window longer. So, some you might increase after 2 weeks, some it might be 6 to 8 weeks, and that's okay if they're starting to see benefit. And so just kind of taking that individualized approach to side effect management.
Absolutely. And I think for each of us, gaining a new skill, right? Using a new medication or treating a disease that we frankly didn't learn a lot about in medical school or residency takes some time. And this might just be the first step, or you might already been doing this, and this is just additional information for you about how to get the medication covered. I would just say my experience with patients is they're so grateful when we talk to them about obesity as a metabolic disease and give them options that work for them. When patients have already told us, I tried reducing my calories, it's my hormones, my hunger, my sleep apnea, my stress, my environment, the access to processed foods, all of those things that are really affecting their ability to maintain a healthy weight. Any other questions? Otherwise, we will log off.
Dr. Oshman, I have a couple different questions.
Go ahead.
So early in my practice, and I'm very gun shy about using Phenrine now, I had a patient that was on it. I usually did the 3-month rule. She had it for 3 months. She left my practice and went somewhere else and got it, I think, probably for another 8 months, but came back to me short of breath. Anyway, the end story was she had cardiomegaly, heart failure, end stage at that point, pretty much, but she was only 27 or 28 years old. Sent her to cardiology. She got a whole full workup. They could not find any other reason except for that medication. And I don't know how often or if you've seen that in the practice, but now I won't use the medication because it scares the daylights out of me. So I'm not naive to the obesity thing, but I try not to use too many medications now because I do use Contrave in my practice, although it's hard to get covered, because I find that that's probably the safest. Topamax some, but people don't like that one as much. But so I don't know if you've seen that or maybe change my opinion on that, but I don't want to do that to another person. If I wouldn't take it or give it to my family, I don't want to give it to anyone else. So it kind of gives me a little scare.
I would put it in this context. Think of all of the other medications you've prescribed. Maybe you haven't had any other catastrophic side effects, but I have. With things that I, was comfortable using, and then that one patient had, the side effect. I put this patient with phentermine in that category for you. Mm-hmm. And I totally understand and probably could give you an example of a medication I feel the same way about. I used to use it. I don't use it as much anymore. A lot of the reason for formulating phentermine topiramate was it uses a much lower dose. of longer acting phentermine and gets around some of those issues. Now, obviously, we're not going to start it in a patient with heart disease, but for an average person without comorbidities, I do feel safe using it. I do use it in my practice, but I'm very careful about patient selection. I would also tell you the other kind of point here is watching someone's weight trajectory. If they are happy at the weight they are at and they do not have any other comorbidities, they are metabolically healthy, I don't feel a strong need to start medications. But when I see someone have had 2 pregnancies and then weight gain, and they are now 60 pounds heavier than they were, even if they're still in their 20s, I do try to find some other way to treat them. And that could be combination, lifestyle, other things.
Okay. My other question is I have a lot of patients that come to me between the ages of 40, maybe 40s to 50s. And I'm been trying to do research on hormones, but they've done everything they can do, exercising. We go through the diet regimen, we go through their exercise routine, and they just can't lose weight. So how much and what is the hormone?
Yeah, it's
doing that.
So just had the same topic at an Obesity Medicine Association conference, and I was hoping I would go in to see the specialist, like, tell me what I can do for my menopausal patients. And they said the same thing you're saying, which is more weight-bearing exercise.
Okay.
The metabolically inactive fat around our hips and subcutaneously has less inflammatory effect and is much less adiposopathic, inflammatory. It's the intra-abdominal fat tissue that I worry most about. And so when I use medications for people in that category, it's because they've moved from having healthy fat to then an overflow of sick fat into the abdomen and visceral tissues. And that's where medications can help. There's no study that suggests that adding hormone replacement therapy, although it's totally reasonable to use for people who are at low risk of heart disease and breast cancer, for hot flashes, would be helpful for obesity. That data is not there.
Okay, yeah, it's a big thing. So I just wondered if you had any more input, because
no, I will tell you as soon as I know. Oh,
yeah.
Absolutely. And I think those are the patients oftentimes that come in distressed because our bodies go through so many changes.
Right. Thank you. I appreciate that.
Thank you so much for staying. And Dr. Azo-Haley, absolutely. I didn't have enough time to give a full treatise on the metabolic causes of obesity, maybe next time, but really thinking about treating this exactly as we do other metabolic diseases. Any other last minute questions, or else we'll say goodbye for the evening?
Thank you so much.
You're welcome. So we're going to actually put this presentation on YouTube for public consumption and not behind a CME firewall. So if you have other folks in the practice you want to share it with or come back and review again, you all have the slides. We're going to keep putting more information up on our website, and we really appreciate your attention. So I'm going to stop screen share, and I'll ask Jackie and Heidi, anything else we need to do before shutting down?
Nope, that's it. Thank you so much, Dr. Oshman.
Thank you, everybody. Have a great evening. Take care.